صباح الخير. The topic of my presentation today will be side effects of radiation therapy to the head and neck. First, we have to know about radiobiology and the biological effects of radiation. Biological effects of radiation may be either cell-death or sublethal injury. Also, we have to know about the reasons for fractionation of the radiation dose, whether reoxygenation, redistribution, repopulation, repair. Also, we are going to talk about the dose-response relationship. To start with, cell death and sublethal injury. When the patient receives radiation, there may be either direct cell death or sublethal injury. Direct cell death occurs if this radiation beam directly hits the nucleus, affecting the DNA and causing breakage of the DNA. As we all know, the nucleus is 1000 times more susceptible to the effect of radiation than the cytoplasm. However, if the radiation beam affects another area of the nucleus, not containing the DNA, or if it affects part of the cytoplasm like mitochondria or something, it can cause sublethal injury, and if given enough time, the cell can repair again, but if it goes immediately through mitotic division, cell death will occur. Most commonly in particulate radiation, like the neutrons and electrons, they mostly cause direct damage to the cell because it has mass. But with the electromagnetic waves, which has no mass, they mostly cause dissociation of the water molecules, which is more abundant in the cell, and causes its dissociation into free radicals, and these free radicals will cause damage to the cell. Then, why we fractionate the dose of radiation? It was a major breakthrough when they reached that the best way is to do fractionation of the radiation dose for the following reasons. First, reoxygenation. They discovered that oxygenated cells are 3 times more sensitive than hypoxic cells to the effect of radiation. And in large tumors, the middle core of the tumor contains hypoxic cells, and so when we give fractions every time, the external part of the tumor, which is containing oxygenated cells, will die and shrink, and there is greater probability that more cells will get oxygenated and become more liable to the effect of radiation. The second reason is redistribution. That's to say, every cell has a life cycle, and during certain parts of the life cycle, it is more susceptible to the effect of radiation than other parts. Like, for example, during the G1 phase and the mitotic phase, the cells are more sensitive to radiation than during the beginning of synthesis of DNA and at the end of synthesis of the DNA. So, by fractionation, we are having more chance to hit the cell during part of its cycle in which it is more susceptible to the effect of radiation. Third reason is repopulation. They discovered that when the tumor is receiving radiation, every time it is shrinking and shrinking, and at a certain point, the remaining tumor cells have a tendency to rapidly divide and repopulate. This occurs at about the 4th week of receiving radiation. Therefore, some protocols now added a booster dose during the 4th and 5th week to control this process of repopulation. The fourth reason is repair. By repair, we mean the repair of sublethal injury which occurred. That's to say, at least you have to keep 6 hours for repair between the fractions of radiation. Also, they discovered that normal cells have more ability for repair than the tumor cells. Last point is about the dose-response relationship. As we mentioned earlier, always we can give radiation till the maximum tolerance of the adjacent normal tissues. Then we are going to talk about side effects of radiation therapy to the head and neck. First, we will have xerostomia or dry mouth. It is of common occurrence and long lasting. The salivary glands have acinar cells and mucus producing cells. The acinar cells are more affected by radiation than the mucus cells. Then the pH will be more acidic and there is 80% reduction in the salivary flow. Management: cyanogogues like bilocarbine tablets which stimulate the surviving acinar cells to produce more saliva. Also, chewing sugarless gum, using artificial saliva, and always drinking a lot of sips of water. Also, by organ engineering, in which they change the mucus secreting cells into acinar cells by injecting a water channel gene inside these cells. Second side effect is mucositis. It is of common occurrence, but it usually subsides 2 to 8 weeks after therapy. It varies in severity. It is a very painful condition, and the patient is always mentioning as if he has pizza burn. He feels this area of mucositis like a pizza burn. Management: first, shield the metallic restorations to prevent backscatter radiation. Mild to moderate mucositis can be managed by bland diet, avoid alcohols and tobacco, topical anesthesia, for example 2% viscous xylocaine solution. A useful mixture consists of 2% viscous xylocaine solution as a topical anesthesia, Benadryl as anti-inflammatory, copictate, which is a protective mucosal coating. Severe mucositis may require interruption of treatment. However, unplanned interruption of radiotherapy is very annoying for the radiotherapist because it allows time for repopulation of the tumor cells, as we said before. Third side effect is radiation cares. Whenever there is xerostomia, you will find radiation cares. It is of common occurrence and usually starts 3 to 6 months after therapy. They occur while the teeth are in the field of radiation or not, as long as the salivary glands are in the field of radiation. Has two patterns, either cervical decay or heavy brown-black discoloration. In the first picture you see cervical decay, and the second picture you see the heavy brown-black discoloration. Management: good oral hygiene, topical fluoride application. We have to use fluoride carriers for such patients, and applying on a daily basis 1% sodium fluoride gel. Also, the use of remineralization solution, periodic checkup and filling of cavities, as well as root canal treatment for cavities with pulp exposure. Another side effect is called ageusia or hypogeusia. Ageusia means loss of taste sensation. This is a common occurrence that starts within the first 2 weeks and gradually returns after 3 to 6 months after completion of the therapy. There is 90% loss of taste acuity, 10% loss of taste cells, 30% loss of taste buds. Management: will be the use of prosthetic appliances that displaces and or shields the tongue, as you see in the picture. Shows atrophy of taste buds. Then we are going to talk about candidiasis or moniliasis. It is a fairly common occurrence, can be considered a fairly common complication that may persist for a long time after completion of treatment, especially with severe xerostomy. Management will be good oral hygiene and frequent rinses with saline or chlorhexidine gluconate solution. Second, keep removed prosthesis clean. Mild to moderate cases can be treated by topical application of anti-mycotic suspension such as nystatin. However, severe cases can be treated systemically by fluconazole or ketoconazole. Trismus is a rare complication, more often if surgery is combined with radiation, and more often if the temporomandibular joint and the muscles of mastication were in the field of radiation. It occurs secondary to fibrosis that occur in the masticatory muscle. Management: isometric exercises for mild cases by manipulating the mandible up and down to increase its range of motion. You can also use simple method like tongue plates by placing tongue plates between the patient's posterior teeth and keep it for 5 to 10 minutes every hour, and when the mouth opening increases you can add more tongue plates until you improve the mouth opening range. Management of more severe cases may require mechanical devices to stretch the musculature and or physical therapy. For example, the dynamic bite opener, which is very effective in increasing mouth opening. The Therabite is also a very effective mechanical device for reducing trismus and increasing the range of motion. However, you should keep in mind that trismus may be due to recurrence or metastasis, and we have to respect the patient for the presence of any metastasis. صباح الخير. Tooth sensitivity. Tooth sensitivity is considered uncommon complication which occur 4 weeks after starting radiotherapy and may persist for a long time. Management will include the use of desensitizing toothpaste such as Sensodyne, also topical application of right gel. In addition, dentine bonding agents such as all bond or universal bond 3 may be helpful. Alopecia or hair loss, it is a common occurrence with radiation, but partial recovery is possible. Edema, it is a fairly common occurrence with tumoricidal dose of irradiation and is seen during treatment and occasionally persists after completion of therapy. Epidermatitis, it is a common occurrence with radiation. Why? As we said before, the skin affected by the radiation because it is of rapidly dividing cells. Any tissue with rapidly dividing cells will be more affected by radiation. It starts with the first 2 weeks of radiation and it is seldom long lasting after completion of therapy. It looks like severe sunburn. It appears on the skin as if there is a severe sunburn. Dysphagia or difficulty in swallowing is also of a fairly common occurrence because the alimentary tract is of rapidly dividing cells, and we said before, any tissue with rapidly dividing cells will be more affected by radiation, and it may persist for a long time after completion of therapy. Herpes simplex, reactivation of herpes simplex virus is a rare occurrence. Can cause recurrent and severe lesions, especially in immunocompromised patients. Management will be systemic acyclovir may be given prophylactically for immunocompromised patients. That's to say, we give it before the appearance of herpes simplex. Small herpetic lesions can be treated topically by Zovirax ointment, which is 5% acyclovir. However, progressive or severe lesions should be treated systemically. Osteoradionecrosis. It is the most serious complication of radiation, but it is not common. That's to say, if I ask you, osteoradionecrosis is of common occurrence, your answer will be false. However, if I ask you, osteoradionecrosis is the most serious complication of radiation, your answer will be true. It is the most serious complication of radiation. It is a radiation-induced, non-healing, hypovascular and hypoxic wound. It is a rare and serious complication. More common in the mandible than in the maxilla because the maxilla has collateral circulation and the mandible has only one blood supply from the inferior dental artery. The classic sequence of its pathogenesis was radiation, trauma, and infection. That's to say, in the old days, they thought that when the patient receives radiation and if he gets trauma and there is exposed bone, the bacteria will come and infect the tissues. However, this concept is not correct because if it is correct, the patient will respond very good to antibiotics, but this is not the case. The new concept developed by Robert Marks in 1983 is that when the patient receives radiation, his tissue will become hypoxic, hypocellular, hypovascular tissue. Hypoxic, hypocellular, hypovascular tissue. We call this the 3H principle. And whenever tissue breakdown occurs, either due to trauma or spontaneously, we all know that spontaneous tissue breakdown after radiation can occur in 39% of cases. 39% of cases. Whenever tissue breakdown occurs, there is chronic non-healing wound. Why? Because of the 3H principle. Chronic non-healing wound. And This tissue will not have the ability to regenerate and cover this defect, and the infection may come on it. But the exact cause is the 3H principle. Therefore, this new concept developed by Robert Marks will be summarized in radiation, then hypoxic hypocellular hypovascular tissue is formed, 3H principle, then tissue breakdown followed by chronic non-healing wound, which we call it osteoradionecrosis. Prevention. First, eliminate all sources of dental infection prior to radiation therapy. Second, stress and maintain oral hygiene. Allow adequate time for healing of extraction site prior to radiotherapy. If we extract teeth, we have to wait for 14 to 21 days before the start of radiotherapy. Also, extraction should be done with adequate alveolectomy to allow suturing without tension, without any sharp bone spicules projecting from the wound, which will cause later on exposure of the tissues and the formation of osteoradionecrosis. So, extraction should be done with adequate alveolectomy and the proper closure without tension. If extraction is deemed necessary after irradiation, it should be done in conjunction with hyperbaric oxygen therapy, and antibiotics. What is hyperbaric oxygen? The patient goes into a chamber containing 100% pure oxygen at 2.4 atmospheric pressure and stay for 90 minutes. This action is called dive, like ROTS. This is done to decrease the risk of osteoradionecrosis. If implants are to be placed in irradiated bone, it should be preceded and followed by hyperbaric oxygen therapy. Preceded and followed by hyperbaric oxygen therapy. The protocol usually includes 20 dives before implant placement and 10 dives after implant placement. Also, remove any metallic superstructure of the implants as well as the abutments and cover the implant fixtures by mucosa if they are in the field of radiation. Why? The implant will act as a hot spot as it is metallic in nature, thus increasing the dose of radiation in the bone around the implant and will cause osteoradionecrosis. If you cannot remove metallic superstructure, it should be shielded with prosthetic appliance that shield the tissues. A useful mixture consists of 2% viscous xylocaine solution as a topical anesthesia, Benadryl as anti-inflammatory, copictate, which is a protective mucosal coating. Role of hyperbaric oxygen. Hyperbaric oxygen is used as an adjunctive modality for treatment of osteoradionecrosis. The patient goes into a chamber containing 100% pure oxygen at 2.4 atmospheric pressure for 90 minutes, as we said before. It has a role as it is bacteriostatic or bactericidal, so it kills the bacteria. In addition, it increases the oxygen-dependent leukocyte microbial killing properties. That's to say, it stimulates the leukocytes to attack the bacteria. Also, it relieves and eliminates orocutaneous fistulas and achieves osseous union in pathological fractures. In addition, it increases the oxygen tension in the tissues, stimulates the collagen synthesis, as well as angiogenesis. We have hyperbaric oxygen chambers available in Egypt in military force hospitals, مستشفيات بتاعت القوات المسلحة, as well as ناصر institutes اللي هو معهد ناصر. Some doctors in these places also tried the use of hyperbaric oxygen in treatment of diabetes, and they said that it reduces the blood sugar level very effectively. Soft tissue necrosis. This is a rare complication present clinically as non-healing ulcer secondary to soft tissue necrosis. So first occur some tissue necrosis and remain as a non-healing ulcer. Management may be either to use hyperbaric oxygen alone or to use hyperbaric oxygen followed by surgical closure of this ulcer. Then we are going to talk about oral care protocol for patients who receive radiation therapy to the head and neck. First, we have to do patient identification. That's to say, there is certain guidelines applied to a following group of patients which require this oral care. These patients will include patients with newly diagnosed head and neck malignancy, patient with persistent or recurrent disease, patients with evidence of metastatic disease to the mouth or associated structures, patient with requirement for maxillofacial prosthesis, that's to say, patient requiring construction of obturators, post-radiation patient, as well as patients with osteoradionecrosis. Coordination of the care. First, we have to know that dental consultation is mandatory before radiation therapy. That's to say, for any patient who is going to receive radiation, first he should go for dental consultation. Second, modification of the usual sequences and nature of dental care may be required. That's to say, we do only essential things for these patients. Then a report should be sent by the dentist to the referring radiotherapist. Severe mucositis may require interruption of treatment. However, unplanned interruption of radiotherapy is very annoying for the radiotherapist because it allows time for repopulation of the tumor cells, as we said before. The following factors should be considered when deciding whether teeth should be restored or removed. That's to say, there are certain guidelines to decide whether these teeth should be restored and keep it or you remove it. First, stages of disease and its prognosis. That's to say, if the condition of the patient is terminal, as the radiotherapist told you, do not extract teeth. Leave it. Second, general health of the patient. If the patient has systemic disease like blood dyscrasias or something, or the tooth is within the tumor site, don't extract this tooth because it may stimulate the tumor to progress. Third, field and dose of projected radiation. That's to say, if this tooth is in the field of radiation or not. This is very important. Also, ability of the patient to cooperate to implement preventive measures. That's to say, if you get a patient with very poor oral hygiene before radiation, what is going to happen after radiation? With severe mucositis. So, for this patient, it is better to do clearance for all of his teeth before the start of radiation. Then, what about complete denture construction for irradiated patient? The time required for insertion of denture depends on many factors. First, the dose of irradiation, the volume of irradiated tissues, general health of the patient, prognosis for tumor control, clinical appearance of the mucosa. Has the patient have been wearing a denture before radiation or not? Has the patient get multiple extraction prior to radiation or not? And bone morphology of the ridge. That's to say, if you get a patient who received a small dose of radiation, the irradiated tissues are very small, general health of the patient is generally good, the clinical appearance of mucosa is not bad, the patient was wearing a denture before, and the patient didn't get any multiple extraction prior to radiation, and the morphology of the ridge is well developed and covered by firm periosteum, you can construct a denture for this patient maybe after 2 months of radiation. However, if you get a patient receiving large dose of radiation and the volume of radiated tissue is very large, the general health of the patient is not good, the patient have done multiple extractions prior to radiation, and bone morphology of the ridge is not satisfactory, you may postpone denture construction for these patients, or you may postpone it totally, that's to say, to indefinite time, because the patient can live on soft food better than getting osteoradionecrosis and its complications. Therefore, depending on the above mentioned factors, complete dentures can be either inserted as early as 2 months after completion of radiotherapy, or may be postponed for as long as 2 years or even indefinitely. Prosthodontic consideration during complete denture construction for irradiated patients. We have to follow basic prosthodontic principles with slight modifications. Let's go step by step. For primary impression, use alternate impression material and avoid impression compound to avoid any thermal burn for the patient. During border molding, do border molding, but guard against overextension. Also, use putty mix for border molding instead of green stick compound, and if you used green stick compound, you should use Vaseline to cover it before placing it in the patient mouth to avoid any thermal trauma. Use mucostatic impression technique for the final impression, and always use a spacer in the special tray. The final impression is made with rubber-based impression material. Avoid using zinc oxide and eugenol or plaster of Paris for final impression making, as they have drying effect and irritating effect on the mucosa. For jaw relation registration, we use the wax wafer technique. We slightly reduce the vertical dimension of occlusion, as this will decrease the masticatory force, and also because these patients usually suffer from some degree of treatments. For the type of occlusion, we use the monoplane occlusion to avoid any lateral interference, which will make the denture less stable. Therefore, monoplane occlusal concept is much preferred in these patients. Avoid using any soft liner as a permanent base, as these patients will have xerostomia, and therefore the mouth is very dry, and the soft liner will have a dragging effect on the mucosa. عامل بالظبط كده زي الفريكشن بتاع كاوتش العربية على الأسفلت. The dragging effect is very traumatic for the mucosa. Do laboratory mount and clinical remount before delivery of the dentures to ensure proper occlusion. Also, use pressure indicating paste to check pressure areas. However, if the patient has severe xerostomia, you should use disclosing wax instead of pressure indicating paste to avoid trauma to the mucosa. Also, lightly polish the fitting surface of the denture to avoid any trauma. Denture and oral hygiene instructions should be given. 24-hour and 48-hour recall appointment in the first week, or even daily examination of the patient for the first week, followed by checkup of this patient every 3 months. Thank you so much.